Assalamu alaikum viewers. Today we will learn about osteoporosis. The learning objectives of today's session are use pathophysiological criteria to differentiate between types of osteoporosis in different clinical scenarios. Now first we will define osteoporosis. It is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue, with a consequent increase in bone fragility and susceptibility to fracture. Usually, it involves femoral head, so there is compression fracture of the head of the femur, and it involves the backache. There is compression fracture of the vertebrae. Osteoporosis can be divided into primary osteoporosis and secondary osteoporosis. Primary osteoporosis is the most common type and occurs without any underlying disease or identifiable secondary cause. It is associated with aging and abnormal hormonal change. It consists of two types: postmenopausal osteoporosis and senile osteoporosis, which is age related. Postmenopausal osteoporosis, as menopause is the event in the woman, it affects women. After menopause, due to estrogen deficiency, leads to increased trabecular bone loss, which makes bone fragile and prone to fractures. Common fracture sites are vertebrae and distal radius. Senile osteoporosis is age-related, occurs in both men and women due to reduced bone formation with aging, affects both trabecular and cortical bone. Common fracture sites are hip and femoral neck. Now, secondary osteoporosis, this occurs due to an identifiable cause such as underlying disease, medication, or lifestyle factor. Causes include endocrine disorders, hypogonadism, gastrointestinal disorders, drugs. Glucocorticoid is a major cause of secondary osteoporosis due to their effect on bone resorption and formation. Now, a clinical scenario: a 60-year-old woman presented with progressive back pain and loss of height over the past 2 years. She experienced menopause at 48 and had not taken hormone replacement therapy. She reported no history of trauma but noted difficulty in maintaining posture due to worsening back pain. As you can see, there is progressive loss of height due to osteoporosis. Now, the key features in this clinical scenario are age for 60 years, menopause started at 48 years, without hormone replacement therapy, progressive back pain and loss of height, which are characteristic signs of vertebral compression fracture secondary to osteoporosis. No history of trauma, ruling out external causes of fracture. Now, this is the gross feature of vertebrae. A is the normal vertebrae and B is the osteoporosis. You can see the A is almost square, the B is compressed. There are fine trabecular bone involving the A vertebra, but there are irregular large trabeculae, and there is uh, concavity on upper and lower borders. There is shortened height, and if we compare the morphological features of these vertebrae, we can say bone structure: dense trabecular framework network with regular alignment in case of normal vertebrae, thin sparse trabeculae with disrupted alignment. Cortical thickness is thick and intact. Thinning cortical bone, bone density, high bone density, and in osteoporosis, low bone density. Trabecular pattern is compact where they are widely spaced in osteoporosis. Mechanical strength, strong and resistant to compression in case of stress in normal, and weak with the higher risk of compression fracture. Appearance: broad and robust vertebral body, narrowed and compressed vertebral body. Pathological implication: represent healthy bone with no signs of stress. indicate osteoporosis and susceptibility to fracture. If we observe the osteoporosis bone in the under microscope, you can see microscopically there are wide spaces and the bony trabecules are thin. Now, what are the pathophysiological mechanism? As there is estrogen deficiency in postmenopausal osteoporosis, it lead to increased formation of osteoclast. Osteoclast are the cells which play an important role in bone resorption, and there is decreased in the osteoblast, which are bone forming cell. How this occurs? Increased osteoclast activity occurs because estrogen suppresses the production of pro-inflammatory cytokines like interleukin 1, interleukin 6, and TNF, which stimulate osteoclast activity. So, when there is loss of estrogen, low estrogen, these inflammatory cytokine increase and they stimulate osteoclast. With estrogen deficiency, there is an increased expression of rankle. Rankle are receptor activator of nuclear factor kappa B ligand, while osteoblast and stromal cells, leading to increased osteoclast formation activity and lifespan. Decreased osteoblastic activity. Estrogen deficiency reduces the production of growth factor like transforming growth factor beta, which play a role in bone formation by osteoblast. Bone microarchitecture deterioration. The trabecular bone, which is more metabolically active, is affected first, resulting in thinning and loss of connectivity. This predisposes the patient to vertebral fractures. So, and another important factor is estrogen deficiency indirectly impairs calcium absorption in the gut. So, there is also adding effect of thinning of the bone. Now, the next scenario is a 75-year-old man comes to the clinic with a history of hip fracture after a minor fall. He has a history of poor dietary calcium intake and minimal physical activity due to sedentary habits. DEXA scan shows a T score of 2.8. So it is basically due to the osteoporosis of senile osteoporosis of head of the femur. Factors in this patient suggest history of senile osteoporosis. Number one is the age. It occurs after 70 years of age when there is decrease in the remodeling. Hip fracture after a minor fall. Fragility fractures, particularly of the hip, are hallmark features of osteoporosis in elderly patient. Then poor dietary calcium intake because calcium gives strength to the bone. If there is poor intake, it is usually exacerbate bone loss associated with aging. Minimal physical activity, physical inactivity contributes to reduced mechanical stimulation of bone remodeling, further accelerating bone loss. And also the X-ray DEXA scan also show a 2.8 score. A T score of 2.5 is diagnostic of osteoporosis, confirming the severity of bone loss. So, why it occurs more common in head of the femur and um, body of the vertebrae? Because the trabecular bone loss begins earlier and is more pronounced than cortical bone loss. Trabecular bone has a high surface area for remodeling, making it more susceptible to osteoclast mediated resorption, and this lead to thinning of trabeculae and loss of structural connectivity, resulting in fragility fractures like vertebrae and hip fracture. Now, there should be more calcium intake, physical activity, and by lifestyle changes, you can prevent osteoporosis. So, please like, share, and subscribe this channel.